I'm Emily. I will be talking about migraines. Primary versus secondary headache. Primary headaches have no known underlying cause, similar to central hypertension, which the etiology is unknown. A secondary headache are the result of another condition causing contraction on a inflammation of pain sensitive structures. Example of a secondary headache is headache due to psychiatric disease, and migraines are classified under primary headaches. What is a migraine? A migraine is a common neurological disease that causes a variety of symptoms, most notably a throbbing, pulsing headache on one side of the head. Here are some types of migraines. The two with the stars next to them, they're the big major types of migraines most people get. A migraine with aura, 50 to 20% people get migraine headaches experience an aura, which is a small warning that is before the pain starts with the migraine. A migraine without aura, it's just a migraine that has no warning that the aura gives. A migraine without pain is also known as a silent migraine. It includes the aura symptom, but not the headache doesn't follow. A hemiplegic migraine includes temporary paralysis or neurological or sensory changes on one side of the body. The onset can be associated with temporary numbness, extreme weakness on one side of the body, tingling sensation, loss of sensation, and dizziness or vision changes. And it sometimes has the head pain. The retinal migraine may have temporary, partial, or complete loss of vision in one of the eyes, associated with a dull ache behind the eyes that may spread to the rest of the head. And vision loss can last about a minute to a month long. Chronic migraine, they occur at least 15 days per month. Symptoms may change frequently and the severity of the pain. Now, migraine with brainstem aura, patients will have vertigo, slurred speech, double vision, or loss of balance, which occur before the headache, feel pain in the back of the head, symptoms associated with the inability to speak properly, ringing ears, and vomiting. The status migrainous is rare and severe type of migraine that lasts longer than 2 hours. So this is a trigeminal-vascular pain pathway. It activates and sensitizes the trigeminal-vascular system, begins the pain part of the migraine. Trigeminal receptive afferents innervating with the meninges is the specific part that begins the pain of the migraine. Trigeminal nucleus caudus, or TNC, and C1, C2 afferents make up the trigeminal-cervical complex, or TCC. Oral migraines are associated with cortical spreading depression, or CSD, which is a short-lasting, intense wave of neural and glial cell depolarization that slowly progresses over the cortex, then following by a long-lasting neural activity depression. Third phase is the headache phase. This is a multifactorial process that is driven by pain mediators and pain inhibitors. Pain activation network is composed of peripheral afferents to central pain structures with cortical, autonomic, and vascular connections. Peripheral afferents include nociceptive, trigeminal ganglion, or TG, non-myelinated C fibers that express calcitonin gene-related peptide, CGRP. The nerves innervate the cranial vasculature and meninges and contribute to the feeling of pain. Neuropeptides, pituitary adenylate cyclase activating protein, polypeptide, and CGRP are all involved in activating the TCC, which is the key part in the migraine pain. In chronic migraine, there are many impairments in the descending modulatory pain pathway. The increased pain states result in increased activity by peripheral sensitization. After there is an increased sensitivity of second-order TNC neurons, and then central sensitization. Finally, the receptive field for nociception at the TNC increases and its input threshold decreases to activate the mind. The fourth phase is the post-REM phase, or also the migraine hangover. It's a period of time from the resolution of headache symptoms until return to baseline following the migraine. From many images of patients, it was found that after a migraine, multiple brain regions have alterations. Reductions in brain blood flow have been observed, along with reductions in blood flow may be caused by activation of certain brain cell nuclei or alterations with this tested. The familial hemiplegic migraines are all genetically inherited, which have there's three different ones that are all having different mutations. They are autosomal dominant inheritance and have phenotypic mutations. The first one, FMH1, has a CNA1A gene, which is located on chromosome 19 and is responsible for encoding the alpha 1A subunit of the PQ type calcium channel. There is a 67 to 89% of having this mutation, and then it's also a missense mutation, which the missense mutation is a single base pair substitution that alters the genetic code. FHM2, which is a mutation, the ATP1A2 gene located on chromosome 1. It's responsible for encoding a catalytic subunit of sodium potassium ATPase. In the diagram, the gray filled stars show the mutation of the ATP1A2, and the white filled stars are other types of mutations, which are R763H and 8606T. The figure was taken from a journal analyzing Portuguese families with familial hemiplegic migraines. The third mutation, which for FMH3, is this SCN1A gene mutation on chromosome 2. It encodes a transmembrane alpha subunit of the brain sodium channel. It has a 100% chance of being inherited. And then from all the mutations, the mutation upset the balance of ions and neurons, which disrupts the normal release of uptake of certain neurotransmitters to the brain. Next, we have risk factors, which the first one, genetics. About 80% of people who get migraine headaches have a first-degree relative with the disease, so it could be like from mother to daughter, and then daughter has an 80% chance of having migraines if the mother does have migraines. Gender migraine headaches happen to women more than men, especially women between the ages of 15 to 55 is more likely common in women because of the influence of hormones. In the graph found from the CDC from 2015, 20% of women, 9.7% of men older than 18 had a migraine in the past 3 months. Overall, women older than 18 years are more likely to have a migraine than men in both sexes. A migraine in the past 3 months decreased and an increase in age from 11% among men between 18 and 44 to 3.4% of men older than 75 years, and from 24.7% among women between 18 and 44 years old to 6.3% among women older than 75 years. So our age range, there's high chance of having migraines if you have them inherited, and then they wean off drastically after around 55. Stress level, high amounts of stress level can trigger a migraine, and then smoking, the nicotine in it has been found to be the main cause of migraines if you do smoke. Signs and symptoms. Symptoms vary in many different people, but here are some of the big symptoms that may happen. An aura, which could be different in speech, such as slurring your speech, sensitivity to light, noise, or sense, nausea, vomiting, loss of appetite, dizziness, blurred vision, feeling warm or feeling very cold. Complications of migraines, first is a stroke, which there's very little evidence that migraine will trigger a stroke, but the chance of a stroke is higher with people who have migraines, especially those who have aura, women, and people under 45. After 50, the odds of having a stroke fall dramatically. Heart disease, Men are more likely to have a myocardial infarction and heart disease. And then women have a higher chance, especially if they do have an aura. Hypertension, there's little evidence. Hypertension may affect the number of migraines, but there's still some evidence. Seizures, at least twice as likely to have a seizure if you also have migraines, and there may be a genetic link between seizures and migraines. Hearing problems, there's more likely to have a sudden loss of hearing, which does in extreme cases fibromyalgia, which causes chronic pain and fatigue, depression, anxiety. If you have both anxiety and migraines, most likely will also have depression. Some research shows aura makes anxiety and depression more likely. PTSD, you're more likely to develop a post-traumatic stress disorder, PTSD. Research has found that the likelihood of having PTSD is 5 times higher than migraines. And then also preterm birth. Little research suggests women with migraines are slightly more likely to have problems, low birth weight, preterm birth, and preeclampsia. And then the symptoms can also worsen during pregnancy, and a new treatment may need to be adjusted. So the differential diagnosis, a healthcare provider will collect a very thorough medical history, which includes the history of headaches, but also includes history of families. Since again, many of them can be inherited. There's also imaging tests, CT, MRI. The EEG is used to rule out seizures by measuring brain activity. They also can do blood tests, and then all of these different tests are to rule out any kind of secondary headache. So for treatments, there's 2 different types physicians can use, which the first one is preventative or prophylactic treatment, which is the medication usually taken frequently or on a regular schedule. Its goal is to reduce the frequency of migraines along with the duration and the severity of them. For the acute treatment, which attempts to abort or reverse the stop of progression of a headache once it has started, so you take it as you get the migraines. So for patients that have migraines but they're less severe. The preventative treatment for migraine medications are anticonvulsants, antidepressants, beta-adrenergic blockers, calcium channel antagonists, and serotonin antagonists. Anticonvulsant example is clonazepam. It is highly potent and long-acting. It acts on a positive allosteric modulator on GABA-A receptors, which are ligand-gate chloride ion-sensitive channels that have the ligand GABA. It increases the frequency of chloride channel opening, resulting in hyperpolarization of neurons and decreased firing, so it provides calming effects on the brain by reducing excitability of neurons. Beta blockers, such as atenolol, selectively binds beta-1 adrenergic receptor in the vascular smooth muscle of the heart, blocking positive inotropic and chronotropic actions of endogenous catecholamines such as norepinephrine or epinephrine, and inhibits sympathetic stimulation. Antidepressants such as amitriptyline, it increases noradrenergic or serotonergic neurotransmission by blocking the norepinephrine or serotonin transporter at presynaptic terminals. Calcium channel antagonists such as verapamil, it inhibits the calcium ion and possibly sodium ion influx through slow channels into conductile and contractile myocardial cells and vascular smooth muscle cells. The serotonin antagonist rizatriptan, it narrows blood vessels in the brain, and then it stops pain signals from being sent to the brain and blocking the release of certain natural substances that cause pain, nausea, and other symptoms of migraine. And then for acute medications, there are NSAIDs, such as ibuprofen, and there's also acetaminophen. And here are all of my